ഒരു 2 മിനിറ്റ് സർ, ജസ്റ്റ് 2 മിനിറ്റ് യൂട്യൂബിൽ ഒന്ന് അപ്ലോഡ് ചെയ്യട്ടെ.
ഹലോ, ആരാ? പറയ്.
എല്ലാവരും ഒന്ന് മ്യൂട്ട് ചെയ്യണേ. സാർ, കൽപ്പന മാഡം. മോഹൻദാസ് സാർ, നമ്മൾ സ്റ്റാർട്ട് ചെയ്യണോ ഓർ ഷുഡ് വി വെയിറ്റ്? മ്യൂട്ടാണേ സാർ, മ്യൂട്ടാണ്.
സ്റ്റാർട്ട് ചെയ്യാം.
Okay. So I'll start, sir. So good evening to one and all. On behalf of IAP Kerala and IAP Trivandrum, we welcome all of you to this wonderful PGTG program, flagship program, that is a State Presidential Action Plan 2024. And this time, Trivandrum is hosting the session, and we have a very interesting case for today. That is a neurology case discussion. So before that, I would like to call upon our IAP State President, Shimi sir, to give the keynote address. Shimi sir. Okay. So I think Shimi sir is not there. Okay. So next I invite our IAP Trivandrum President, Hariprasad sir, to give the felicitation. Over to Hariprasad sir.
Thank you. Dear and respected senior teachers and IAP leaders and my dear friends, I'm very happy to be with all of you today, and I think we have got an excellent program going on. That's IAP PG Club, and I'm very happy that to see our own my own teacher and mentor Sushma Madam is here. Also, all of our dear Srinivasan sir is here, and also Purushottam sir. So thank you all senior teachers for joining for this program today. And also we have got eminent faculty members of pediatrics from across Kerala, like Dr. Anandakeshavan and Dr. Mohan that's joining along with us. And today we have got an excellent discussion on a neurology case, and discussed by none other than very eminent pediatric neurologist, Dr. Kalpana. And along with her, we have got Dr. Swapna from Gokulam, and the person is Dr. Shakeel. So I'm sure this will be an excellent case discussion, and I wish this program all success. So back to Benno to continue the proceedings. Thank you.
Thank you very much, sir. Just mute everyone, sorry. Yeah, so next I would like to call upon our beloved Anandakeshavan sir, scientific convener of IAP Kerala State, to speak a few words. Over to Anandakeshavan sir.
Muted.
Good evening. Thank you, Dr. Benno. Respected Chairperson, Dr. Hariprasad, Scientific Academic Program Coordinator, Dr. Mohandas sir. As already mentioned, teachers, Dr. Purushottam sir, Dr. Sushma Madam, Dr. Srinivasan sir, and finally my teacher, Dr. Kalpana Madam, and all other Dr. Hariprasad, and all my dear friends, and also Program Coordinator, Dr. Priya Srinivasan and Dr. Rashmi Raj. It's outside I would like to congratulate IAP Trivandrum for organizing a wonderful academic session. And also last week also they arranged a very wonderful case. Today we are lucky to have a eminent teacher, Dr. Kalpana Madam. So I again congratulate Dr. Mohandas for organizing the program very systematically. And I wish the program, today's program, all the best, all success. Thank you. Jai Hind, Jai IAP.
Thank you very much, sir. Now I would like to invite our IAP State Coordinator PG Teaching Program, Mohandas sir, to speak a few words.
Thank you, Benno. I would like to congratulate Trivandrum branch headed by Dr. Hariprasad and Benno, and also the coordinators there, Dr. Priya and Lakshmi, for organizing this week's program. And this week's mentor is Dr. Swapna Pillai from Gokulam Medical College, and case is presented by Dr. Shakeel, and the discussant is Kalpana Madam. So we are eagerly waiting for the discussion. Thank you all once more. And I would like to thank all the senior faculty here for being present here. And I think now the faculty are more, but it is good that whatever knowledge we gather from here will be transferred to our students. So there is, and also many will be watching this in the YouTube also. So we need not be bothered much about the attendance. Thank you.
Thank you very much, sir. Now I would like to call upon our chairperson, Kalpana Madam, to speak a few words.
Good evening. I'm always happy to be here in the PG club with all my beloved teachers and senior faculty as well as dear friends. And I'm not, so we can directly go to the case, inviting Shakeel to present the case.
Over to Dr. Shakeel. We'll start off with the case discussion.
Shall I start, madam?
Shakeel, visible or
Yes.
please?
Okay.
You can start.
Okay, so good evening to everyone. Today I'll be presenting a case. Today I'll be presenting a case of a 12-year-old male child who is hailing from Nilamir, Kollam, Kerala, and the informant is mother and the information is reliable. So the presenting complaints are the child was brought with a history of repeated falls since 5 years of age and difficulty in getting up from the floor and climbing the stairs since 6 years of age. So coming to the history of the presenting illness, the boy was apparently normal till 5 years of age. He could walk, he was walking normally, running normally, he was playing with his peers, he could skip and he could speak sentences with normal vision and hearing. Hence, he was enrolled in a preschool. That is when the mother noticed certain difficulties in her child. Like he preferred to sit and play more than standing. And the mother could also appreciate the enlargement of his calf muscles. And while after running or walking a certain distance, he developed mild pain over his legs. So for all these complaints, she had taken her child to different doctors. They were reassured and the child was given some medications like analgesics and supplements. But for further probing into the history.
Slides. Sir, the slides and sir cut short in here. 45.
Sorry for that. I think Dr. Shakeel can actually unmute and then he can present. I think he's muted now.
Okay. So further probing into the history, she gave us a list of complaints which was mainly suggestive of a proximal weakness, mainly involving his lower limb. So what were the complaints? The mother noticed that the child, but this was around by 5.5 to 6 years. The mother noticed that the child would fall frequently while
1
running.
minute, Shakeel, and never tell that it is like weakness of proximal muscle, nothing. You have to tell that what are the complaints the mother told.
Sure.
So the inferences can be made later on.
Sure.
While taking the history, it should be the history only. Okay.
Okay, sure. So the mother noticed that the child would fall frequently while running, and there was a difficulty in running and walking for him, and he was unable to walk fast compared to his peers. He preferred a slow walking. He used to take broad steps and keeping both feet apart. The mother could also appreciate the unsteadiness of the hips from one side to another while walking, and his abdomen was protruded. And he also had a difficulty in climbing from the floor and climbing upstairs. So while he was seated on the floor, the mother noticed that he used to take the support of his hands on his way to get up. And previously, he used to get up within few seconds. But now, since last 2-3 years, he takes longer time and he requires assistance from his mother in getting up from the floor.
Continue.
Yes, ma'am. Okay. So he was able to kick the ball initially, but now he has a difficulty, and he was able to wear footwear without slippage, and no dragging of feet was noticed by the mother. And his symptoms, they did not vary diagonally, and there was no aggravating or relieving factors, and it was not associated with easy fatigability or excessive muscle cramps. And since the last 2 years, he prefers toe walking, and he needed the help of his mother more than before for ambulation. So he also had difficulty in getting up from the lying down position. He used to roll over and get up, but now he requires assistance from his mother in order to get up from the supine position. Presently, he also has a difficulty in raising his head, which he could do without difficulty earlier. Okay, so but over these years, he did not face any difficulty in combing his hair, in dressing and undressing his shirt, in picking up the objects placed at a higher location, and he was able to remove his shoes and socks. He also did not have any difficulty to write, or he did not have a history of any bad handwriting, no difficulty in buttoning or unbuttoning his shirt, and he did not have a difficulty in mixing food or holding a pen, opening the bottle or screwing the tap. And he also did not have any difficulty in holding and releasing an object, and he also had a normal handshake. And there was no history suggestive of any higher mental function involvement, like there was no history of any abnormal movements, there was no history of seizures, no history of loss of consciousness, no change in behavior. His speech was normal. There was no history of any cognitive decline, or no stiffening of the limbs was appreciated by the mother. And he also did not present with any complaints of any cranial nerve involvement, as evidenced by a normal smell, normal vision, no restriction of eyeball movements, no squint, no dropping of eyelids. He also did not have any difficulty in chewing, normal facial. He had a normal facial expression, no difficulty in drinking from a straw or blowing balloons. He also had no history of any eye opening during sleep, or no taste disturbances or drooling. His hearing was normal. He did not have any symptoms like swallowing difficulty, alteration in the voice volume, or changing in the voice volume, and no history of any nasal regurgitation or fits. And he also had normal neck movements and shoulder shrugging, and no abnormal movements of tongue, or normal tongue was noted by the mother. And he also had a normal tongue position. And he also did not have any symptoms suggestive of cerebellar involvement, as evidenced by he had a normal balance. He did not sway on standing. There was no change in handwriting, and he was able to bring water to the mouth without spillage. He also had a normal perception of sensations, warmth and cold, and there was no history suggestive of any palpitations, abnormal sweating, dizziness, or syncope, and there was no history of any incontinence or constipation. And the mother had noticed a spinal curvature since the last 2 years, but it was not associated with any pain or tenderness. Also, he did not have any history suggestive of breathlessness or exertional dyspnea at rest, and palpitations, excessive sweating, chest pain, or edema. He also did not have a history of frequent respiratory tract infections or hospitalizations. And also, he did not have any history of any excessive daytime sleeping or fragmented sleep, history of snoring, etc., or early morning headaches. And there was also no history suggestive of ptosis or drooping of eyelids, easy fatigability, or diurnal variation associated with the weakness. There was also no history of rash over the face or hands, and there was no history of any muscle tenderness. There was also no history suggestive of any severe pain or cramps in the muscle after exercise or after walking a certain distance. And there was no history of repeated exacerbation, and his weakness was not episodic. There was no triggering factors like fever, exercise, etc. And there was no history of any twitching of the muscles. And there was no difficulty in holding or releasing an object. And the mother also did not give a history of any constipation in her child, intolerance to cold, and excessive tiredness. There was no loss of facial expressions, and there was no history of any muscle stiffness on exposure to the cold. So coming to the briefly describe the course of the illness. For these complaints at 7 years, he was referred by an orthopedician to a pediatric neurologist in view of an abnormal blood investigation. But at a tertiary center, he was admitted and evaluated, which included genetic testing. The mother was advised that her child could possibly have a progressive muscular disease, was started on some oral medications, and was advised physiotherapy. So, but around 7.5 years of age, the genetic testing had confirmed the diagnosis in her child, and she was asked to continue the medications and physiotherapy. He had a younger sibling, a male child. He was also screened and was also normal, but the mother was not willing for screening. According to the mother, the symptoms, it seems to be worsening despite physiotherapy since the last 3 years, and more so since the last 1 year. Now, currently, since 6 years of age, his dependency towards the mother has increased. He is currently ambulant, but with difficulty up to a distance of around 3 to 5 meters, following which he used to fall and he needed assistance up to 15 meters. And there is a history of, and currently he has a history of frequent falling, and he's scared to walk without support. And he is unable to climb even one step at a time. His house is in the ground floor with 2 steps, and he has to be carried inside by his mother and younger sibling. And he also requires assistance in getting up from the bed, and as well as he requires assistance in going to the toilet. But he can bath on his own seated in a low-lying stool. Also, he can brush his teeth now normally as before. And he sits and plays with his mother, but he has difficulty in moving around. And nowadays, he predominantly stays indoors with increased screen time, and he eats food with his family. He does homework on his own. He used to attend regularly, but he's not attending a nearby government school regularly. But he's not attending since the last 3 months, not probably due to traveling issues. And nowadays, he borrows notes from his friends and he studies online. For attending the test, he goes to the school and he gets good marks with good scholastic performance. So moving on to the treatment history, he is on oral medication since 7 years of age, and he had underwent a cardiac consultation, and they advised him some cardiac medication since 10.5 years of age, and he has been undergoing physiotherapy since 8 years of age. He used to do it at a test. He used to do it at a center before, but now the mother helps. He's not attending the center, and the mother helps with the physiotherapy on alternate days. And he undergoes follow-up with echo yearly. Moving on to the past history, there was no significant history or no history of any recurrent hospitalization before 5 years of age. And moving on to the antenatal history, it was a spontaneously conceived pregnancy at 36 years. The mother was 36 years at the time of conception. It was a booked and
you can just leave that.
Sure.
Okay, next.
And the quickening was perceived throughout.
That's okay. Next slide.
The natal history, it was uneventful. There was no history of any birth asphyxia or anything.
Okay. Okay.
And postnatally, there was no history of NICU admission. Like
That also you just leave. That are all normal. What is abnormal, you can mention.
Okay, sure. And moving on to the developmental history, you can see that the child had had attained all developmental milestones appropriate for age in all the 4 domains like gross motor, fine motor, except at the 5 years in the gross motor area where he had a pain on walking and standing and climbing. He had a mild gross motor. He had a gross motor delay at the 5 years of age, and there was no impulsivity or no behavior abnormality noted. He was peaceful and he was affectionate. And further, moving on after 5 years, you can see that there was a significant delay.
Gross motor, you need not tell. Just tell about the language. Everything is normal. He is conversing.
Yeah, language was normal. He is conversing. He could speak well. He could do the homeworks, and his cognition and adaptive milestones were also normal.
Just continue. Next slide.
The diet history,
okay.
There was nothing significant.
Okay. Next.
Immunization history also, he had taken. He is vaccinated till 5 years of age, and no optional vaccines was taken. And moving on to the family history, he is the firstborn of a non-consanguineous marriage. He has a younger sibling who is 8 years old, and he is normal. Now there was a history like his father had a history of recurrent fractures since early childhood, and he had undergone some blood test, and he was diagnosed to have some skeletal lesion at 16 years of age, and he is wheelchair bound since 22 years of age. But there are no detailed records available, and he did not have any symptoms suggestive of any upper limb involvement. And there was no history of any contractures or deformities in other or weaknesses in other members of the family. And there was no history of any sudden or premature deaths. And there was no similar history among the male children of the maternal sibling as well as maternal grandmother sibling. And this is the pedigree chart, the 3-generation pedigree chart. Moving on to the socio-economic.
Just leave that. Just leave that.
So coming to the summary. Yes, ma'am.
So now we will discuss. Just please put the first slide or just leave this. Okay, fine. So it was a very detailed history, but there are some points which I want to tell. One is never tell like this each system. We will be asking symptoms corresponding to each part like. Motor system, sensory system, cerebellar system. But when we are writing like that, there can be problems also, because you have mentioned that there is no unsteadiness when you are telling cerebellar signs. But this child is walking with an unsteady gait, isn't it? That is not because of the cerebellar thing, but actually the child is walking with an unsteady gait because of the weakness. So there may be conflicts also. So when you are presenting, you can say that the child is normal till 5 years of age, and when we can say that when the child was starting schooling or in preschool classes itself, he was more sedentary compared to others, and when they are walking or running, he will be a little behind. And later on, what happened is?
Later on, he used to have frequent falls and difficulty in getting up from the floor as well as climbing the stairs.
Okay. So usually what happens was he will be, there will be difficulty in, they will be a little slower in walking compared to others. And when there is a tendency for climbing and stairs, that will be, he will be finding it difficult. He may need assistance, or he may need assistance of the rails, isn't it? So you can present that like initially he was a little slow compared to others, and later on he needed assistance while climbing stairs, and later in on getting up from sitting also he needs the assistance of the hand, and he used to climb on his legs like that. So he needed assistance of the hands, and later on what happened, he needed even support to get up from the sitting position, for support of some persons. And then in the lying down position also he had difficulty to get up and raise, and then he had difficulty in raising his neck in the lying down posture. And in upper limb, it is mentioned that he was able to do all the jobs completely. Whether it is completely true or not, but according to all his activities of daily living are being done without any support using the upper limb. So he can ask whether he can take a heavy object and raise it above the head like that. Something you can ask to identify whether there is any
Weakness of the proximal.
weakness. So here, what is suggestive? Everything, most of this is suggestive of a proximal muscle weakness of the lower limb. And distal muscle, you said that the child is able to wear the slippers and there is no slipping of chappals that you have mentioned.
Yes.
And walking, he is walking on his feet, isn't it?
Yes, ma'am.
Sometimes there is a toe walking is there, isn't
Yes,
it?
ma'am. We had mentioned that nowadays, like last 2-3 years, he's been toe walking.
So how will you explain that? Is it a distal weakness?
Toe walking could usually, could possibly be due to contractures, development of contractures. Due to
Development of contractures is one, and another may be a weakness of the
distal dorsiflexus.
dorsiflexus, weakness of dorsiflexus. So there can be weakness of dorsiflexus also, or there can be contractures. Both of this. So there is a suggestion that even though the proximal weakness is more, there is a weakness of the distal muscles, or there may be contractures because he is walking on toes. And upper limb is absolutely normal, but he has problem with this trunk because side to side turning also is difficult, and there is weakness of the neck muscles. Facial muscles are all spared. Eye muscles are all spared. There is no drooping thing. And then you have mentioned that there is no diurnal variation, but fatigability, when you are telling, there will be a problem, isn't it? Because when he walks for a little distance, he cannot walk further because he is very weak, isn't it?
Yes.
So there is no fatigability is a problem there. So whenever you are presenting each and everything, you have to be careful. And regarding the diagnosis and the treatment and different centers he has gone, and the genetic diagnosis that is made and other tests done, follow-up done, all this you need not mention, because once you tell like that, one is you sometimes can be the diagnosis can be even missed. So if it is a diagnosis was made incorrectly also, you will be just carried away. Second thing is that in most of the examiners may not like telling about all the genetic test, screening, everything done. So tell about what the history of the illness from the mothers. Okay. So he has predominant. So just now summarize. What other points anyone wants to say? We want to. Gaurav has said discuss all the negative history in detail. So here the positive. Shakeel, tell the positive history. Just tell the positive history.
Positive history is like he had difficulty in getting up from the floor and climbing upstairs, suggestive of a proximal muscle weakness.
So this neck flexor weakness, truncal weakness and all, you should not write there in the this one. You can write that he had lying down position is difficult. Okay. And these are all very important, and he has mentioned all this clearly. Next slide.
There was
so upper limb, these are the things that you have to look for the distal weakness: buttoning, unbuttoning, and mixing the food, taking it into the mouth. Whether he is feeding by himself?
Yes, ma'am. He is taking food by himself.
So taking it into the mouth. Combing the hair is actually combing is. It needs both the proximal muscle and the distal muscle. Actual combing is using the distal muscles, but raising the limb up and combing the hair, that needs the proximal muscle also. And also he is able to pick up weights. Picking up weights above the level of the head. So if they are able to get it, that means that proximal muscle will be definitely, the upper limb will be better than the lower limb. And so these are the things. And handshake is usually in Western areas, but if he is telling, it's okay. Okay, then next slide. Higher mental functions, he is conscious and there is no seizures. That shows that there is
no UMN.
UMN, like brain and is not much affected. Then the cranial nerve, we have mentioned all the cranial nerves. And most important will be the eye vision abnormalities, then the extraocular muscle abnormalities, then the 7th nerve, 9th, 10th, and 9th and 10th will be more important. Okay, next. Then this one, cerebellar sense, there is no need to write it in separately. And there is no normal perception of sensation. He's able to, you can tell the like, he's able to appreciate warmth and cold normally, and there is no paresthesia or something, no pin and needle sensation like that, because we are not examining, isn't it? And autonomic symptoms are not there. Okay, next one. And what about the no history of breathlessness on exertion, palpitation, excessive sweating?
Suggest of any cardiac involvement, like complication.
Okay. Cardiac involvement and breathlessness on exertion may be because of respiratory insufficiency also.
Yes.
Okay. Then recurrent respiratory tract infections because of?
Like respiratory involvement mainly.
Respiratory muscle involvement may be a reason, or even the lower cranial nerve involvement if it is occurring. Recurrent aspirations can occur. Cranial muscles, if it is involved, you can get aspiration and infections. Then no history of snoring, fragmented sleep. This also, snoring is because when he gets it is obstructive sleep apnea is what you are mentioning. Yes. Even otherwise also these children will have difficulty in sleeping, and there may be carbon dioxide retention, and so they may be getting up frequently at the time of sleep, and so daytime there may be more tiredness. Okay.
Shakeel.
Yes, ma'am.
The presenting complaint is frequent fall. Can you enumerate what are the causes of frequent fall?
Frequent falling can be due to any cerebellar disturbances, any visual disturbances, or any proximal muscle weakness.
Any other problem?
So when you are telling the presenting complaint is frequent falls, always you have to tell how he falls. Is it a fall with a loss of consciousness? So that will be a seizure or a syncope-like thing. Or if the consciousness is retained, then it is often due to problems with the muscles, joints, etc. So the problem of fall, so usually when there is a weakness of the knee extensors, he will buckle and fall. Okay, buckling of knees and falling. And also then when he becomes very, very weak, there will be swaying to either side, and he may lose the balance and he may fall. Distally, when he is walking on toes, the chance for toppling and falling also will be more. So in pyramidal weakness, will you get recurrent falls?
Yes, ma'am. Pyramidal weakness also we can get recurrent falls.
So they will trip on small objects and they can fall.
They can. Yes.
Then when there is if they are walking in a narrow area and if they are falling, it is due to when walking on a narrow base, like walking on the field, like that. If they are falling, what will be the commonest cause? If they are swaying to either side on walking,
like any cerebellar involvement.
Cerebellar involvement also can result in, and also joint problems like knock knees. That is very, very common in children. that also can result in fall. These are all fall with retained awareness. The other one is fall with loss of consciousness. That is how we differentiate. We discuss the falls. So when you are presenting the presenting symptom is mentioned as recurrent falls, then you have to discuss the falls a little more in detail. Otherwise, you can say that difficulty in walking and difficulty in getting up from sitting position or lying down position, and then you can tell about the recurrent falls. And then one more symptom that you have mentioned is the calf muscle hypertrophy.
Yes.
Or prominent calves. What are the conditions where you can get a prominent calf or calf muscle hypertrophy?
So the calf muscle hypertrophy can be divided into true hypertrophy and pseudo hypertrophy. The true hypertrophy can be seen in conditions like myotonic congenita, paramyotonia, and the false hypertrophy. Pseudo hypertrophy.
What is myotonia?
Myotonia is the like inability to relax the relaxation of the muscles after contraction.
Okay, so the muscle will remain continuously contracted, isn't it? So that is why the muscle actually gets hypertrophied, just like a isometric exercise, isn't it? So the muscle remains contracted almost all the time. So that is why in myotonia congenita, we get a infant Hercules appearance. So all the muscles will get hypertrophied in myotonia congenita. Okay. Any other conditions where you can get
in pseudo hypertrophy? You can get in muscular dystrophies like Duchenne's and Becker's. You can also get in pseudo hypertrophy in hypothyroidism with syndrome associated like Cocker debris semilianism.
In muscular dystrophies, you will get it only in Duchenne and Becker only?
Duchenne's, Becker's, and limb girdle muscular dystrophies also you can get.
Sarcoglycanopathies. That is one type of autosomal recessive. Muscular dystrophies like sarcoglycanopathy. So a girl child presenting with calf muscle hypertrophy, you have to think about sarcoglycanopathy. A child who is not having that much weakness but calf muscle hypertrophy only.
Emery-Dreifuss muscular dystrophy.
Emery-Dreifuss will not. It is upper limb is predominant. So calf muscle hypertrophy. When you are seeing a child with a Duchenne muscular dystrophy, we often examine the mother, isn't it? So the carriers of Duchenne muscular dystrophy can have
calf muscle hypertrophy.
And then there are many infiltrations like this trichiniasis. Then what is the parasite infestation? And also you have mentioned about hypothyroidism. That is one important one. What is that syndrome called?
Cocker debris semilianism.
Cocker debris semilian syndrome. So the child will be having short stature and also
hypertrophic muscles, infant Herculean.
Yes, amyloidosis, but in children it is very, very rare. Okay. Okay. Yes.
Muscle disease.
Then summarize.
Okay. To summarize my case, this is a case of a 12-year-old boy born to a non-consanguineous parents who was developing normally until he was 5 years of age.
One second. I just missed the family history. In family history, you have mentioned that the father is actually in wheelchair since the age of 22 years.
Yes, ma'am.
And there is history of some fractures. We don't know what exactly it is, isn't it? So in that case, always we have to think about some autosomal dominant conditions also. Okay. Autosomal dominant type of muscular dystrophies, like the limb girdle muscular dystrophy, a few of them can present early.
Yes.
Okay. So that also is important because father has his wheelchair bound since the age of 22 years. And we have to ask regarding the weakness, if it is there or not, why he is sitting, whether he is able to stand up by himself, or is there any contracts, any other deformities are there, or is what is like. At least we have to see a photo of the father also, because what is his presentation and whether he is doing everything according to history. Upper limb involvement is not there.
Yes.
Because autosomal dominant type of limb girdle muscular dystrophies can have variable age of onset, and some of them may present later, and in the next generation it can come little more early, and the upper limb will be remaining unaffected even at 40-50 years also. Okay. Then history among male children of maternal siblings. So always, because here he has a only one male child, that is at this time he is clinically normal, and but maternal siblings and grandmaternal siblings you have to ask, because Duchenne muscular dystrophy is a
X-linked
X-linked
recessive.
recessive. So always ask regarding maternal uncles. So when you are asking, you ask regarding maternal uncles as well as paternal uncles and aunts, but you have to concentrate on that.
Maternal side.
Otherwise, there may be sometimes there may be feeling like discrimination and all. Okay, then continue with the summary.
So to summarize my case, this is a case of a 12-year-old boy born to a non-consanguineous parents who was developing normally until he was 5 years of age, and he has shown symptoms suggestive of a proximal weakness and progressive of his lower limbs, and with weakness of his trunk and neck muscles, which was not associated with any diurnal variation or fatigability, episodic worsening or aggravating or relieving factors. From the history, his upper limb muscles are unaffected. There is no history suggestive of any weakness in the muscles of his face, mouth, eyes, nor there are any indications of his CNS involvement or complications. And there is no positive family history. His condition has worsened over the time.
And there's no positive family history. It is better to tell that his father is wheelchair bound. Because we don't know. Only thing is there was some fractures they are telling. We don't know what exactly is the problem. So there is history of wheelchair dependence in the father, whether significant or not, we are not sure. There is no history of any other family members affected. Okay.
And his condition, it has worsened over time, leading to increased dependence and motor disability by his current age, that is 12 years.
Okay.
So from this, I would like to place his lesion as predominantly an LMN lesion, and with his symptoms suggestive of like
so there is symptoms of slowly progressive proximal muscle weakness of the lower limb, then which has affected the trunk as well as the neck muscles, without any significant affection of the upper limbs or the respiratory muscles or other cranial muscles. So predominantly it is a motor involvement only. There is no history suggestive of any sensory involvement. So predominantly motor involvement. Then you can, and there is a calf muscle hypertrophy also. There is a prominent calf which is noticed from the age of 5 years. With a prominent calf muscle hypertrophy according to the history. You can say that whether there is any thinning of muscle that is noticed at any time, or whether there is any abnormal prominence of other muscles. What are the other muscles that can be involved?
Other muscles, the second most commonly involved is the tongue muscles. Then the infraspinatus, the deltoid muscles can be involved. Then the gastrocnemius muscle and the vastus lateral.
Gastrocnemius is the one that is the calf muscle, isn't it? So another one will be the brachioradialis. Okay. Brachioradialis can be affected. Okay. So we can say that it is a predominantly motor involvement. Okay. No sensory involvement. Then when it is a purely motor involvement, among the LMN causes, what are the parts that can be affected?
So among the element, the anterior horn cell could be affected.
Okay.
And there is no history suggestive
So
of any
just mention the anterior horn cell.
anti-muscle.
Then
Then the neuro.
can it be a now roots or radicals?
No, there is no history of any back pain or.
No, not like it is not the
distal.
presentation. What I am telling is just think about the anatomy. So when we say LMN, it starts from the anterior horn cell, then the anterior root or the peripheral nerve, then the neuromuscular junction, and the muscle.
Muscles.
Okay.
Yes.
So from among all these, so only motor involvement can be seen in anterior horn cell involvement. Then there can be rarely motor axonal type of neuropathies can be there. But in this child with a very slow onset and progression, they don't know exactly at what age it has started, because he was always slow and he always preferred to lie down more and sit and play rather than walk or run and play. So at what age it has started, we don't exactly know. So it is a very slow onset, very gradual progression, and over 7 years he has become almost like a not ambulant or just ambulant for 1 or 2, 3 meters only. Okay, so it is a slow in onset, slowly and then gradually progressive, and okay, like that. So then the neuromuscular junction also presents as a pure motor one. Then the muscle. So a peripheral nerve, when we are taking the peripheral nerve, it will be usually motor plus sensory. So then we have the hereditary motor sensory neuropathies, isn't it?
Yes.
But they are mostly motor plus sensory, but few can be motor neuropathies alone. But predominantly they are motor plus sensory, and the involvement will be more distal muscles will be, because the nerve degeneration starts at the end. So the longest nerve will be affected first, and so the distal part will be affected first and then the proximal. So the neuromuscular junction and the muscle. Okay. So among that, the neuromuscular junction involvement, what will be the features? What will be the predominant features?
There will be features suggestive of any EC fatigability or any diurnal variation.
So these are the two things. Among that, the EC fatigability, when the child is having severe weakness, the fatigability may be there. Okay. Okay.
And any symptoms suggestive of any ocular involvement.
So always think of extraocular ptosis and extraocular muscle involvement. That is the commonest presentation. And also the facial muscles and the lower cranial nerves can be involved. And usually upper limb is affected and then the lower limb weakness can occur. Okay, so then the diurnal variation and EC fatigability. So towards in the morning, the child will be relatively normal. So then the muscles. So anterior horn cells and the muscles are the two areas which are most probably involved. So in anterior horn cell disease, which disease you can think of?
Like spinomuscular atrophy type 3, juvenile onset.
So type 3 or juvenile onset Kujelberg-Wellander disease. So here the onset may be juvenile, like 2 years, 3 years, like that, and it is slowly progressive. But it may be a little more slower. Then calf muscle hypertrophy can be there in both. Okay. So SMA also can have calf muscle hypertrophy. Then among the muscle diseases, what are the things that you can think of?
The sarcoglycanopathies.
Sarcoglycanopathies.
Then,
so you can say that it can be muscular dystrophy in a younger child becoming non-ambulant by the end of first decade. The commonest will be the Duchenne muscular dystrophy. Okay. Yes. So Duchenne muscular dystrophy can be your first possibility. Only thing is father is affected. So we can think about other limb girdle type of muscular dystrophies also. Any other disease you can think of?
Myotonic dystrophy.
Myotonic dystrophy, will it present like this?
Usually there'll be facial involvement and dysmorphic faces. And
Interestingly, actually, there will be more muscle wasting in myotonic dystrophy, and the distal muscles will be more affected than the proximal muscles. And this myotonia congenita will have severe hypertrophy of muscles, but the weakness is not there. And what is the feature that is there for these conditions? That is the myotonia. What is myotonia? What will it present like?
like difficulty to relax the contracted muscles, like difficulty in handshakes, difficulty in releasing the grip.
So difficulty in releasing the grip. So when they are getting down from the bus, there will be difficulty in releasing the grip. And also in morning, when they want to open the eyes, there will be difficult. They have to just rub it on for some time. And there is a second wind phenomenon. After some time, this myotonia goes off. In the initial part, the myotonia will be very severe, and after some time, it will go off. So when they want to do rapid alternating movements, like drawing water from a well, you can have difficulty in releasing the hands alternately like that. And also opening the eyes in the morning or when they're after sleeping. So that is about myotonia. Any other conditions? Any other storage diseases?
Storage like Pompey's disease, but in adults, Pompey's disease, then like McArdle's disease.
Among Pompey's disease and McArdle's disease, which one you will put you higher up in the diagnosis?
McArdle's.
What is the presentation of McArdle's disease?
McArdle's, like after walking or after exercising, there will be severe pain or cramps in the legs.
Okay, so there will be pain and cramps after exercising for some time. Okay, yes. That is not there here. And in between, they will be relatively okay. But the juvenile Pompey's will just present like a lower limb weakness and predominantly proximal muscle weakness. So always think of Pompey's disease whenever you are discussing on this. And hypothyroidism also you can put it in because that is a treatable condition.
Yes.
So Pompey's disease, hypothyroidism, all you can think of. And so how will you differentiate between an anterior horn cell disease and a muscle disease?
So with anterior horn cell disease, the wasting will be disproportionate to the weakness. But in muscular disease, it is almost both are proportionate to each other. Then in anterior horn cell as well as in the muscular disease, there will be symmetrical weakness, but and proximal weakness. And in anterior horn cell disease, like
so anterior horn cell disease, when we are thinking of spinal muscular atrophy, it is proximal weakness. But the prototype of anterior horn cell disease is in adults, which one? Anterior horn cell, that's the motor neuron.
Type 4 SMA.
Type 4 SMA is also a genetic disease, but an acquired disease.
Acquired polio or
polio, no. Adults, when there is very much wasting and as well as fasciculation.
Amyotrophic lateral sclerosis.
Vivek is mentioned as motor neuron disease, isn't it? Amyotrophic lateral sclerosis. Motor neuron disease. Motor neuron disease is the prototype. So there it is the distal weakness that is very characteristic. And some group of muscles may be affected, some group of muscles may not be affected. So, but in SMA, it is characteristically proximal muscle weakness. And it is symmetrical, proximal more than distal. And the wasting is more prominent compared to weakness. And regarding the reflexes?
There will be areflexia in anterior horn cell disease.
So reflexes will be completely lost, but in muscle disease?
It may be preserved or diminished.
Preserved or diminished. So it will be diminished, but
Initially.
it won't be completely absent most of the time, and the distal reflexes it is proportionate to the degree of involvement. So if whichever muscle is maximally affected, that reflexes will be reduced, or it even can be absent, and often the ankle jerk will be retained till late. Okay.
Yes.
So, and SMA, can you get calf muscle hypertrophy?
Yes, ma'am. In type 3 SMA, we can get calf muscle.
So type 3 SMA, you can get calf muscle hypertrophy. So the two important differential diagnoses will be, one is a type 3 SMA, because the father is also affected. But it will be, SMA is, what is the inheritance of SMA?
Autosomal recessive.
It is recessive. So when father is affected, the chance is less. So any autosomal dominant condition you can think as the limb girdle muscular dystrophy. Limb girdle muscular dystrophy can have any autosomal recessive, dominant disease. What is the one of the important character of an autosomal dominant disease regarding the severity of disease? In one generation and the next generation, when comparing the father and the son, who will be more severely affected?
The father.
Is it like that?
The next generation will be more
affected. What is the word that is used? Tanya. What is the word in genetic terms? It is anticipation, yes.
Anticipation.
So anticipation is always there in autosomal dominant disorders, but here the presentation is not exactly like a limb girdle muscular dystrophy regarding the progression of the disease, but we can say that the autosomal dominant type of limb girdle muscular dystrophy also can be thought of as the father is wheelchair bound. Okay. Otherwise, we will be definitely going on for a Duchenne type of muscular dystrophy and SMA type 3. So these are the two important diagnoses, and also we can think about the Pompe's disease also. And another important point is this hypertrophy of some muscles and hypertrophy of part of muscle and part may be atrophied. All these are characteristic of
Limb girdle.
All muscular dystrophies. Sometimes you can get some muscles maybe here also. The calf will be hypertrophied, the quadriceps will be atrophied. The pectorals in Duchenne muscular dystrophy, part of pectoral, the sternal head may be atrophied, the clavicular head may be hypertrophied. In the back, what you will get, the supraspinatus, infraspinatus may be hypertrophied, but the latissimus dorsi will be atrophied. That is the valley sign, isn't it?
Right.
Okay. Just continue.
So moving on to the general examination, the child is alert at the time of examination and afebrile, and he is cooperative for the examination. There was no pallor, icterus, cyanosis, clumping, lymphadenopathy, or edema noted in this child. And moving on to the vitals, his pulse rate was at 85 beats per minute. It was regular, normal volume, normal character, and all peripheral pulses were felt. Respiratory rate was around 23 breaths per minute, regular, with normal work of breathing, and he had a single breath count of 22 per minute. And he's coming to his blood pressure. In his right upper limb, it was 110/70 millimeters of mercury, and left lower limb, it was 106/70 millimeters of mercury in sitting position. And his,
why it is like that? Usually it is not. The upper limb it is more and lower limb it is less. Okay, continue.
And his capillary refill time was less than 3 seconds and normal. His saturation was 99% in the right upper limb and 98% in the left lower limb. And he was afebrile. And moving on to the head to foot examination, the head and scalp, it appeared normal. And moving on to the face, he had a Cushingoid face with normal expressions, normal shape, no dysmorphisms or no bitemporal hole. On his eyes, he had normal eyes with no squint, no ptosis, no cataract, and he had a normal eye movements or no ophthalmoparesis. He had no rashes around the eye and he had normal eyelids. And moving on to the ears, it was normal and there was no low set ears noted, and his nose was normal. Coming to his oral cavity, it was normal. There was no high arch palate. There was no tongue hypertrophy, no fasciculations, and he had a good dental hygiene. Moving on to the skin manifestations, he had a normal skin pigmentation. There was no neurocutaneous markers noted, no striae or no dry skin, or no scars, rashes, or any trophic ulcers. And also, there was no hyperpigmented knuckles. And moving on to the nails, it was normal.
Why hyperpigmented knuckles is mentioned?
Ma'am, it could be seen in inflammatory myositis like dermatomyositis.
Okay. Okay.
So moving on to
myositis, the hyperpigmentation, there it is not hyperpigmented knuckles. It is the papules, isn't it?
Godron's papules.
Hyperpigmented knuckles is usually seen in which condition?
Megaloblastic anemia.
Megaloblastic anemia. Okay. B12 deficiency. Okay.
So moving on to the chest, he had gynecomastia, and there was no chest wall deformities, and his abdomen was protruded, but no striae was noted. His genitalia was normal. His bilateral testis was in the scrotum, and it was not undescended. And his extremities, it appears symmetrical. It was normal in length. Bilateral calves were hypertrophied. There was ankle contractures in both of his ankles. There was no pes cavus or hammer toes or no hyperlaxity of the distal joints. And moving on to the spine, he had scoliosis.
And also, whenever we are telling contractures, this laxity, both are actually opposite, isn't it?
Yes.
So when you are telling ankle contractures, never tell it is no hyperlaxity. Okay. Of distal part. Proximal, if there is some laxity, you can mention. Okay.
And moving on to his spine, there was scoliosis and there was valley sign. Here you can appreciate the scoliosis or the lateral bending, and there is prominence of the deltoid as well as the infraspinatus muscle and the posterior fold of posterior axillary fold, which is also called as valley sign.
Posterior axillary fold is atrophied.
Atrophy.
Okay,
Yeah. Another word.
So
moving on to
short stated. Okay.
Moving on to his anthropometry, his weight was observed to be 40 kilograms and expected weight was 39.5 kilograms, and it was at the 50th percentile. His height was 133 centimeters with expected for his age around 149 centimeters, and it was at the 3rd centile. And his BMI was noted to be 22.7, and according to the IAP, the chart for the boys, he fell on the obese category.
Okay. Why the short stature?
It could be due to the chronic use of steroids, and as well as
only that or any other thing.
And he is also non-ambulant, and then due to absent less sunshine exposure due to vitamin D.
So that will produce short stature.
Short stature.
Any others? Any other cause for Vivek? Any other cause? He is having scoliosis, isn't it? Scoliosis is one of the important factors. And the posturing, abdominal postures, even lumbar lordosis also can result in this one. Okay. Okay, continue. And steroids is definitely one of the cause.
Moving on to his central nervous system examination, his higher mental functions were normal. He was conscious. He was cheerful. He was oriented to time, place, and person with normal speech, and he could do the mathematical calculations which I had asked him to do. And moving on to his cranial nerve examination, his cranial nerve 1, there was normal sense of smell. Cranial nerve 2, there was normal vision, normal near vision, and normal field of vision. And he identified that there was no defect in color vision. Bilateral pupils were equally reactive to light, both direct and consensual. And his fundus was normal. Moving on to the 3, 4, 6 cranial nerve, there was no squint, and he had normal extraocular movements or no head tilt or deviation. Moving on to the cranial nerve 5, he had normal power of the mastication muscles,
Okay, so
normal
all the
facial,
cranial nerves are normal.
all the cranials are
Normal neck movements, you can write it as normal side to side neck movements.
normal.
Okay. Okay, continue.
So moving on to his motor system, he had a lordotic posture, battling gait, and he had Gower sign positive. So I would like to show a video on that. In this video, you can appreciate that he has difficulty in getting up from sitting position, and you can appreciate the lordotic, the battling gait and the protuberant abdomen, as well as you can appreciate that he needs support from his mother in ambulation.
So it is almost he is dependent, isn't it? He needs support even for walking a few steps. Okay.
In this second video, you could appreciate that he's the Gower signs positive. He's using his hand to play. He's
So even
placing his hand on the
it is,
chest.
usually
on
we
the
do
knees.
it when we make the child sit on the floor. Here, even from the wheelchair, he needs the support of the hand. So this also is Gower sign. Okay.
Moving on to the bulk, on inspection, he had bilateral calf muscle hypertrophy, and he had deltoid as well as infraspinatus hypertrophy, which I had shown before. And on palpation, his muscles were firm and non-tender. And on measurements, it was measured at all identical
What is the
points.
consistency like? So we will differentiate true and pseudo hypertrophy. So when you are touching the muscle, it will appear, what is the word?
It will appear firm and
Firm and
Rubbery.
Rubbery, because there is more fat is there, isn't it? So it is firm and rubbery in consistency. The other one will be firm, just like the muscle, isn't it? This one has a different feel. Okay.
Moving on to the measurements, in the right arm it was 22.5 centimeters, left it was 23 centimeters.
So there is no difference in both sides.
Significant difference in the of measurement both sides. His tone was also normal. Moving on to the power, like in the hip area, flexion and extension, the power was on the right and the left side, the power was grade 3, and on abduction and adduction it was grade 4, and on the coming to the knee area, on flexion it was grade 3.
When you are testing the flexion and extension, often the extension will be more weak.
Extension.
So extension may not be grade 3 because on lying down, is he able to lift the leg backwards?
Yes, ma'am, he is able to do.
So it may be a little more, usually it will be weak. It may be 2 or 3 minus, something like that. Because extension will be more weak. That is why he needs support. Okay.
And on knee, on flexion as well as extension, on both right and left side, it was grade 3 power. And on ankle, his plantar flexion was grade 4, but his dorsiflexion was grade 3 power. And moving on to the upper limbs, there was no significant loss of power, both in the right as well as in the left upper limb. And his neck lifting was weak. He was not able to raise his head from the bed. And as well as his trunk muscles were weak, as suggested by
So neck lifting, how will you actually test the power of neck muscles?
We have to fix his proximal shoulder joint, and we have to ask him to raise his head from the.
So you should do it in the lying down posture.
Lying down position.
So when you are doing it in the lying down posture, and you ask him to lift the neck, it is against gravity.
Against gravity.
When the patient is sitting and you are asking to move forwards, that is with the gravity eliminated, okay, or gravity assisted. So in sitting, they may be able to use a little more force, but in lying down, they may not be able to lift it against gravity. So you can say that like that.
And his trunk muscles were also weak, like he was not able to rise from the supine position, and he needed support for that actually. And his hand grip, he had a strong hand grip, And coming to the gait and coordination, as you have seen on the video before, he had a waddling gait. And moving on to the
So
reflexes.
waddling gait, just tell something about waddling gait.
Waddling gait, it is usually due to the weakness of the hip extensors, mainly the gluteus medius muscle, as well as the gluteus maximus
Is
muscle.
it hip extensor? Gluteus medius and minimus? Dr. Sajjana?
Hip abductors.
They are hip abductors, isn't it? Hip abductors. So what will happen normally when you are walking? When you are lifting the one leg?
The opposite side gluteus medius muscle contracts.
They have to
raise the
contracts and maintains it in the higher position. So when that muscles are weak, when you are lifting that limb, the gluteal fold sags down. That is why it goes like paddling to both sides, just like a duck walking. Okay.
So moving on to reflex, all his reflexes were like grade 2 reflex, except at the knee area where the reflexes were slightly sluggish, and his plantars were flexors. The superficial reflexes, both abdominal as well as cremasteric reflex was present, and Beaver's sign was negative, and there was no myotonia.
So Beaver's sign, what does that indicate?
Beaver's sign could indicate the weakness of lower abdominal muscles. When you flex the neck, there will be upward movement of the umbilicus.
So why in this patient you have mentioned about the Beaver's sign?
Like in the facioscapulohumeral disease, you can get.
So that is that is an only in facioscapulohumeral muscular dystrophy, the Beaver's sign can be positive. So when it is positive, we can mention that. Otherwise, when you are mentioning the Beaver's sign, usually we use it for what? Lower muscle involvement, as in a transverse myelitis. We will be like that. So, but Beaver's sign, because there is a differential involvement between the lower and upper abdominal muscles in facioscapulohumeral muscular dystrophy, you can get it as positive. Okay.
And moving on to the other parts of the central nervous system, he had no involuntary movements, and sensory system, his touch, temperature, pain, pressure, vibration, and proprioception were all intact. Moving on to the cerebellar system, he had no ataxia, nystagmus, and he had a normal finger nose test and no dysthyrokinesia. His spine and cranium, there was scoliosis present, but there was no tenderness or gibbous, and also he had a normal skull, and there was no meningeal cells elicited. Moving on to the other systems.
Okay. So actually, they're telling this Gover sign, Valley sign, and the gait can be at the end of the motor examination. Otherwise, what will happen is you will be telling everything at the beginning, isn't it? So motor examination, you can mention the size, tone, power, coordination, reflexes, everything, and then you can tell about the gait. That is otherwise, when we are just starting about the gait, everything will be discussed at that point itself. Some people even include the gait under the higher functions, but when you are including that in the higher functions, the problem happens is that all the muscle power, weakness, everything will be discussed at that point, and you will not get time to think or time to discuss like that. Okay, so better to add the gait, but if some examiner asks you to tell it before, then you can see. Okay.
So moving on to the other systems, in his cardiovascular system, apex beat was felt at the left fifth and intercostal space medial to midclavicular line. His JVP was not elevated, and his S1, S2 was normal with no abnormal pulsations, and there was no cardiomegaly. And on respiratory system, here a good chest expansion.
Did you examine that? Did you examine cardiovascular system? Yes.
Yes, ma'am.
Because there can be cardiomegaly because he's 12 years. Okay. Yeah.
And on his respiratory system, he had a good chest expansion around 4 to 4.5 centimeters. His voice volume was good, and his single breath count was around 22 per minute. No, there was no tachypnea. Normal vesicular breath sounds were noted, and there was no added sounds. And on per-abdomen examination, it was soft, non-tender. There was no organomegaly, and bowel sounds were
heard. Okay. So here cardiovascular system is important because one is in many muscular dystrophies it can be involved. Any other disease, in Pompe's disease
Pompe's
also
disease.
there can be cardiomyopathies. Respiratory system is important because there can be restrictive
Lung
type
disease.
of lung disease also. Then abdomen is important because
In Pompe's disease and all, you can get
in Pompe's
hepatomegaly.
disease or other glycogen storage diseases with muscle weakness, there can be organomegaly. Okay.
Okay, so to summarize the entire case, this is a case of a 12-year-old boy who presented with progressive.
1 minute, Dr. Shija has asked any explanation why the upper limb is totally spared at the age of 10, 12 years. Because I'm not seeing the patient, I cannot say. Okay. Okay, next.
Summarize the case. This is the case of a 12-year-old boy who presented with progressive inherited muscle weakness.
So from the clinical history itself, we could get that it is a muscle disease.
Muscle weakness. Okay.
Yes.
So
Muscle disease. And there is proximal muscle weakness involving the lower limb, but and the trunk and the neck. So lower limb, trunk and the neck, but the upper limb is completely spared. It is a little odd actually, isn't it? So from that we can say that it can be either anterior horn cell disease and or the muscle disease with calf hypertrophy. And after examination, what is the finding that helped you to say that it is more of muscle disease compared to anterior horn cell disease?
His examination, it confirmed the weakness in the proximal muscles of lower limb, neck,
that
and
is
front
there in
muscles.
both the condition, isn't it? Okay.
And with calf and deltoid muscle hypertrophy. His reflexes were preserved with absent meningeal or cerebellar signs.
So reflexes are relatively preserved with a sluggish knee jerk and retained ankle jerk. Okay. So that is more in favor of a muscle disease compared to anterior horn cell disease. In anterior horn cell disease, usually reflexes will be lost early. Even before the weakness is severe, the reflexes will be lost early. So anterior horn cell disease is less likely compared to muscle disease.
And he also had a lordotic posture, waddling gait, and Gover's sign and scoliosis, which is classically seen in
all these, the lordotic posture, the Gover's sign, scoliosis, all can occur in any condition associated with a proximal muscle weakness. Okay. The valley sign need not be, because that is more in favor of a muscle disease, especially Duchenne's.
Yes.
Any other signs are described in other type of muscular dystrophies?
Polyhill sign, which is seen in the facioscapulohumeral disease. Then
what is it called?
Polyhill sign.
Polyhill sign. So there will be different mounts will be seen. There will be hypertrophy of the trapezius, and we can see the supraspinatus as 2 or 3 mounts, and as well as the deltoid. And one more sign in facioscapulohumeral disease.
Shawl sign.
What is it?
Shawl sign.
Shawl sign.
Polyhill sign.
Then Popeye sign. So the Popeye, that is a lower forearm part will be normal or slightly more prominent, and the upper arm will be atrophied. So they're just like the cartoon character Popeye. So that is the Popeye sign. Then in muscle disease, have you heard of Kalpanopathy?
Yes, ma'am. Because winging of the scapula, severe winging.
There can be winging of the scapula can be there, and one important point is there will be weakness of the adductors. So when they are getting up from the lying down posture, the limb will be abducted. So the limb abduction sign is one of the commonest finding that is seen in Kalpanopathy. So clinically we can diagnose. Kalpanopathy can be autosomal, recessive, or dominant. Okay. Recessive will be having a severe presentation, and dominant can be a milder presentation. So when the child is sitting up in a stool or something, we can see the limbs kept abducted. Then there is a sign that is called diamond on quadriceps.
In dysferlinopathy.
Dysferlinopathy. So these are the signs by which we can say some of this. Okay. So when we are telling again, don't jump directly to Duchenne muscular dystrophy. You can see that there is proximal muscle weakness, predominant calf muscle hypertrophy. So and the reflexes are sluggish but retained, and the ankle jerk is present.
Yes.
So that shows that it is a muscle disease, is more in favor of a muscle disease than anterior muscle disease, and he has the progression of disease to such an extent that he's almost not able to walk independently on his own. So that much weakness in a boy of 12 years, we will be thinking Duchenne muscular dystrophy as the first possibility. So muscular dystrophy, you put as a general term, and there is a history of wheelchair boundness in father. So an autosomal dominant muscular dystrophy also I have to think of, and because of the progression, so fast progression in this child, Duchenne muscular dystrophy, and the present the valley sign, and the presence of valley sign, Gower sign, and all this, and the fast progression in a male child, I'll be the possibility of Duchenne is also very high. You can present it like that. Then POMPs can be put as a differential diagnosis, because that is a muscle, again a muscle disease. Okay. Then lower down, we will keep the spinal muscular atrophy lower down. Okay.
So these are the differentials which I would like to think of, like Becker's muscular dystrophy, limb girdle muscular dystrophy, Kalpana spinal muscular atrophy with juvenile POMPs.
So Becker's muscular dystrophy presenting at 5 years is rather very unusual, and also loss of ambulation at 12 years. So Duchenne will, after Duchenne, you can say it as limb girdle muscular dystrophy. Limb girdle muscular dystrophy, the severe forms are autosomal recessive. Okay. And Kalpanopathy, that is also a part of limb girdle muscular dystrophy, isn't it?
Okay.
So autosomal recessive type muscular dystrophy with calf muscle hypertrophy is sarcoglycanopathy. Okay.
Yes.
Sarcoglycanopathy. Then you can say Kalpanopathy, which can be dominant or recessive. And then spinal muscular atrophy, and also you can say about the POMPs.
Juvenile POMPs.
Okay.
So this is how you evaluate a child with.
So what will be the presentation in a classical Duchenne muscular dystrophy? What will be the age of onset of walking?
Around 3 to 5 years, the child will have difficulty.
No. What I asked is at what age the child starts walking?
Normal.
Around 1 year.
1 year, 2 years.
1 year.
Is it like that? Anyone have read?
There can be slight delay in the gross motor.
Yes.
There can be slight delay in gross motor.
There will be some delay in walking. Usually it is like 15 to 17 months, something like that. And often once they start walking, they may be walking on toes also. And so up to sitting, they may be attained relatively normally. After that, there will be a delay often. And what will be the investigation that will be abnormal when they have a fever like that? When you are this child at 1 year, the child is just able to sit up but is not walking. So when the child is admitted with a fever and you do a liver function test, the liver function test can be abnormal, isn't it? So in any case, if a child is otherwise normal, liver is normal, but the liver function enzymes, transaminitis is there, but there is no jaundice, no other bleeding time, clotting time, nothing is affected. And even when you are testing the liver, ultrasound is also normal, and even the biopsy is also normal. So whenever when you are getting an undiagnosed case of transaminitis, send a CPK also, and examine the child for any evidence of weakness. You will get very mild evidence of weakness. So Duchenne muscular dystrophy, nowadays we are diagnosing it even at the age of 1 year. So they will be coming with a delay in walking. And sometimes we will just send because the child may be a little hypotonic, we may send a CPK and CPK will come in thousands, 10,000s like that. So one of the most common type of presentation is OTPT, and they will be being investigated, and one child is actually sent for genetic examination, and after the genetic diagnosis came as Duchenne muscular dystrophy. So always see for proximal muscle weakness and do a CPK. So isolated transaminitis. So what that we usually see in dengue fever and all, but after some time it will go off. This will persist. Why it is getting elevated? AST, ALT. Why the AST and ALT are elevated in muscle disease? Anyone?
Because of inflammation. Like,
What inflammation?
the OT, SGOT can be present in the muscles as well. So when there is
Yes, that is
muscle,
it. So AST and ALT are, there are muscle, brain, liver, everywhere it is there. That is why. Okay. So when the muscle is damaged, you will get just like your LDH is raised, AST and ALT can also be elevated. And CPK also is present in the brain, muscle, isn't it? Heart. Okay. Okay. So the investigation that is that will give you most clue will be a CPK. And EMG in this case we can do it. We can get a myopathic pattern, but most often nowadays we usually won't do, because when the CPK is raised, what is the difference when you tell that it is a myopathy and a muscular dystrophy?
the CPK will be markedly raised in myopathies, like in the areas of 15,000.
Just think of once again. In Duchenne, how is it mildly elevated or markedly elevated?
Markedly elevated.
So Duchenne is a muscular dystrophy. Isn't it?
Yes. Myopathy, that can be.
It can be normal or mildly elevated. Just 5 to 10 times, not more than that. So we can expect up to 1,000, not more than that. Why? In muscular dystrophies, there is an actual destruction of the muscle fibers. So the muscle fibers are getting destroyed and the enzyme will be released. The other one in myopathies. Myopathy is a general term of any disease affecting the muscle. When we are telling congenital myopathies, what do you mean?
Which can be inherited. It can be present since birth.
Dystrophy is not inherited?
Dystrophy is also inherited.
Okay. So dystrophy should be general. Definitely it is a heritable diseases where there is actual destruction of muscle fibers. Congenital myopathy is due to a structural abnormality in the muscle. Okay. When the muscle is structurally abnormal, the apoptosis may be a little more. The normal anticipated death of the cell will be faster because the muscle is structurally abnormal. So you will get a slight rise in the CPK, not a marked rise. Even in SMA, you can get a CPK is slight raised. But when it is very much raised, more than 10 times, then think of dystrophic process. Okay. Now conduction studies mainly for neuropathies.
Neuropathies.
So now conduction studies may not give anything in this. Muscle MRI is coming in a big way. Differential involvement of the muscle can be identified in different type of muscle diseases. Previously, even now we are doing the muscle testing and identifying the muscle that is affected. More than that, we can identify which muscles, some muscles of the anterior compartment may be, for certain rare myopathies, it is very, very useful. And also in inflammatory myopathies, we can differentiate different types. But now we have different muscle antibodies can be identified. So different muscle inflammatory myopathies or muscle MRI is, so muscle MRI is coming in a big way, but the whole body MRI should be done. Then, so what we will do is, we will do a CPK. If the CPK is very high, then what will you do?
Then we'll go for a genetic testing,
Genetic testing means what?
like multiplex PCR or MLPA initially to look for the deletions.
So, for Duchenne muscular dystrophy, there are usually large deletions, sir.
Large deletion.
More than 2 may be lost. So, we will be going for either MLPA or multiplex PCR.
Yes.
Okay. So, if Duchenne is not your diagnosis, if it is a limb-girdle muscular dystrophy, what will you do?
We can do the muscle biopsy like, to look for
Then
immunohistochemistry.
you won't go for genetic testing?
Like we can also do the genetic testing, like if it is autosomal recessive, we can find out the abnormal like sarcoglycan gene.
Which test you will do? Which test you will do in among the genetic test? So MLPA is for deletions and duplications, isn't it? Specific deletions, duplications. But if one gene alone is affected,
and Sanger's
can be done, but if you know the exact gene, limb-girdle muscular dystrophy is a large group. With each disease, there will be multiple genes, isn't it? In that case, what will you do?
The whole exome sequencing.
But when the findings, so the next generation sequencing is the correct answer. And also, here we are very sure that it is a muscle disease. So we can have a clinical exome or a muscular dystrophy myopathy panel is there. So that will check all the genes involved in that. Okay.
Sure.
So targeted panel testing can be done, or a clinical exome sequencing. So you are telling the most possible diagnosis, and so they will be checking all the genes. Okay. And the muscle biopsy, so in a Duchenne muscular dystrophy, you are doing an MLPA, and MLPA is coming as negative.
Then we can do the Sanger's sequencing, like if there is duplications or any point mutations, we can.
You have bundled together two things. One is duplication and one is point mutation. If it is duplication, MLPA will pick up. Okay. If it is a point mutation, that is, if it is a single gene involvement, then you have to do the
next generation
sequencing. Or Sanger sequencing, for if you are completely 100% sure that it is the Duchenne, then we can go for a Sanger also. Okay. But most of the time we will be, now the next generation is much faster and less time consuming. Sanger means each and every gene you have to go for that. Muscle biopsy, when will you do?
When the phenotype is of Duchenne muscular dystrophy, but the genetic test is inconclusive, then we can.
So genetic test, the MLPA as well as the point mutation testing is negative, then you can go for. Previously, we used to do the muscle biopsy before and then the genetic testing. Now genetic testing is much easier, so we are going for genetic. In muscle biopsy, what will you expect? Or muscle biopsy, when we are thinking of muscle biopsy, what are the things that you have to keep in mind?
There'll be inflammatory endomysial connective tissue proliferation.
What is the test that you are going to do? And which muscle you will select?
Vastus lateralis.
Any other difference of opinion? Dr. Gaurav? Anyone? Any difference of opinion? Is it gastrocnemius? So actually, a moderately involved muscle will be done. So usually when the lower limb is severely involved, as in this case, we will usually go for an upper limb muscle like a deltoid. Because when the muscle is severely affected, what will happen? It will be replaced by fat and fibrous tissue. So the muscle fibers will be very much less. Okay. So you do it in a moderately affected muscle. That is one. Second thing is where you will do. Is it possible in all the labs, or do they need anything extra? Because when you are doing a muscle biopsy and do the routine H&D stain, you will see the inflammatory changes and the
Macrophages.
degenerative findings, the central nucleation, the target fibers, in all these, and the muscle will be replaced by fat
Connective tissue
like that. But that will be seen in all the muscular dystrophies. We cannot differentiate between the muscular dystrophies based on your H&D. So what else we will do?
We can go for like immunohistochemistry.
So immunohistochemistry, and the histochemistry also, when we are thinking of congenital myopathies, histochemistry is also important, because we can identify the central nucleation, the mini-core, multi-core, or nemalin, everything can be identified by histochemical testing and immunohistochemistry. For that, you need a fresh section, fresh frozen section, and immediately it should be mounted, and these are vital stains. So in a formalin fixed thing, you cannot do it. You have to immediately freeze it in liquid nitrogen and immediately do the test. So it should be sent to a lab where there are facilities. It should be done in a place where there are facilities for histochemical and immunohistochemical staining. Otherwise, don't go for the muscle biopsy. And it can be sent within 2 or 3 hours, dipped in a cotton mix in saline. Now, you should not add any fixatives. Okay. And if needed, electron microscopy can also be done. And what will be the preservative for electron microscopy?
Formalin.
It is all same, isn't it? Glutaraldehyde, 3% glutaraldehyde. Okay, next.
So
just show that.
This was the genetic testing, which was done at around 7.5 years of age.
So there is deletion of 4 exons, 18 to 21, which is relatively rare. Okay. So it is a Duchenne muscular dystrophy. Okay.
Management.
So just tell the management.
So moving on to the management, you can improve his quality of life at the home. Once you diagnose with Duchenne muscular dystrophy, like you can ask the parents to keep his.
So at the time of diagnosis, what was the medicine that was given?
Medicine was given was oral corticosteroids.
What about the oral corticosteroids? Is it indicated, or is it useful or not?
The corticosteroids is useful in reducing the inflammation. So deflazacort or prednisone.
Why you want to reduce the inflammation? Why we are giving, is steroids useful or not?
Yes, ma'am, it's useful.
So it will slow the progression of the disease. It will prolong the period of independent ambulation. So we will usually start by 3 to 5 years when it is diagnosed, and we will continue till they lose the ambulation. So it is, what is the dose that is advised?
If you are giving prednisone, it is 0.75 mg per kg per day, and if it is deflazacort, it is 0.75 9 mg per kg per
kg per day.
daily dose is now recommended.
So what are the problems that can come with steroids?
So the complications of steroids are like hypertension, altered blood sugar levels like hyperglycemia, then growth retardation, obesity, overweight,
So
then
short stature,
cataract, short stature,
obesity, cataract, then
hypertension, hyperglycemia.
that we have mentioned. But that is if we are constantly checking, most of the time it is not there. But more important than that, steroids, long-term steroids.
Increase in bone density like osteoporosis.
So, osteoporosis is very, very important, isn't it?
Yes.
So when they can get fractures with the mild trauma, the rib fracture, the vertebral fractures, the compression fractures are very, very common. So even just bending, they may get fractures. So what can be done for that?
We can do a DEXA scan and we can supplement it with calcium and vitamin D supplementation.
Anything more than that?
We can also
If we are doing a DEXA scan and finding that there is some osteoporosis,
we can give testosterone or
testosterone allade vera onnum kodukkan pattille.
zolendronate,
Bisphosphonate.
So biphosphonate or bisphosphonates. So alendronate or solendronate can be given, isn't it? So that is very important. You have to see for the bone health. Very, very important. Because many children come with vertebral fractures. So that is one of the reason for the early fusion of epiphysis is one of the reason. Then this compression fractures and so the vertebral height also will come down, isn't it?
Yes.
And so these are the complications. And the obesity is one of the most common. This child is also obese according to BMI, isn't it?
Yes.
So to avoid that, what are the things that you have to do that? One is this calcium phosphorus alkaline phosphatase checking and calcium supplementation, vitamin D supplementation. And if there are features of osteoporosis, you have to give biphosphonates. Okay. And then
we can advise him some aerobic exercises like yoga, swimming with assistance.
So graded exercise or graded exercises and it should not be very severe exercises because the muscle is already weak. If you are doing maximum exercise, the muscle will get degenerated fast. So there is a moderate type of exercises and swimming and aerobic exercises are useful. And so what else? The obesity should be avoided at all costs. So one important thing is that these children are very immobile or very little there. So the calories required are much less than a child of corresponding age.
Yes.
So you have to reduce the calories. Otherwise they will gain weight and the weight gain will further decrease the mobility, isn't it? Decrease the mobility, increase the scoliosis, the respiratory, the capacity also will come down as the child becomes obese, isn't it? So obesity should be avoided and you have to give protein-rich foods, sweets and
less of carbohydrates and fats, more of vegetables, proteins.
Proteins should be added.
And dairy products.
Then any vaccine you want to take?
Vaccine, we can a pneumococcal vaccine as well as influenza vaccine to prevent pneumonia or respiratory infections.
This is very, very important because if they get infection, because the lung function will be compromised and it will result in more damage to the lung and they may need CPAP or something later on. So respiratory function assessment is very important. Then periodic reviews and respiratory exercises are also important. And then
physiotherapy.
And you have to see whether there is carbon dioxide retention and if needed, night time if you are giving chest physiotherapy is important. Then CPAP when you are
non-invasive ventilation.
That will be useful when so the child will be more fresh in the daytime. And mobility should be as far as possible, you have to make them mobile. Once they, if they are starting becoming immobile and sitting in the wheelchair, then the scoliosis increases very fast, and then the restrictive, this lung disease will come in. Then cardiology consultation regarding the cardiology.
Like the echo, it has to be done yearly. So when they were given a preventive medications, most probably it is an AC inhibitor to prevent the afterload and decrease the afterload and to prevent progression to cardiomyopathy and congestive cardiac failure.
You have to do very frequent cardiac checkups and start by the time the child reaches 9 or 10, you have to start with ACE inhibitor. Usually perindopril is one that is used, and that is important. Then they need actually the mental health support is also very important. And the screen time, avoiding screen time is actually something that is very difficult in these children, because that will be the only engagement for them. Most of the time they will be at home, and so you can give it for some time, and then you can give some other, and you make them engaged with some place that can be done with the hand, something like that. Okay. Then this newer drugs.
Newer drugs like antisense oligonucleotide exon 53 51 skipping like eterplacin, golopersin. Then recombinant
we
DNA.
have genetic
recombinant DNA cell therapy like LABDs can be used.
So
Then,
regarding the first is exon skipping or antisense oligonucleotide therapy. For that, which are all portions we are using? 51?
Exon 51 and 53.
And one
53.
more is 51, 53 and 45 is also available. Okay. So 51, the amenable mutations are not 51. That is like 48 to 50 like that. 51 should be present. Then only the stop codon is reading through will happen. Okay. So when we are keeping, if this 18 to 20 is there, you can put that in a table. You can put that there is a calculation, whether it is amenable or not, they will tell. 18 and 20 is not amenable to any of these. And then regarding the gene therapy, what is the important problem with regard to gene therapy? Duchenne protein, that is dystrophin is a very large protein. It has 17, it's a very large protein. So our microorganism AAV9 is a very small adeno-associated virus, isn't it? So you cannot keep all the genes, all the total protein cannot be, you cannot add on to the gene. So what they do is now they are using a small part of the dystrophin, which can be that part of the gene is integrated, so that somewhat functional gene can be integrated. So that is microdystrophin, and that has come in to 2023, isn't it?
Yes.
What is the name? What is
LABDs.
the name? LABDs. Okay. So these are all coming, and but regarding the antisense oligonucleotide therapy, the injection has to be given how frequently?
Subcutaneously once in a month.
Once in a week. Every week you have to give. And the drug is very, very costly, and the improvement is very, very slow. And it is the worsening is avoided, but the improvement is not very, very commendable improvement is not there. And this one is actually the gene therapy is a single injection. It has just been approved, and we don't know how much benefit it will cause. Okay. Is Purushothaman sir there?
I was enjoying the excellent coverage of the topic, as Srinivasan sir pointed out, and completely covered those aspects. And I think Mender and Shakeel did a wonderful job because he answered
Everything was covered.
the questions. 3 points, Shakeel.
Yes.
Is in the calculation of the anthropometry and the BMI.
Yes.
The height part, as Madam already pointed out, in this case, there is a spinal deformity and the neck flux and all. You need to modify, give allowance for that height measurement. Always mention about the height of the parents also. In this case, father's height is difficult to measure. All those things, okay. But your comment about the BMI, 22.7 is obese. That's wrong.
According to
Equivalent less than 23.
Sir, there are age-related cutoffs are there, sir.
23 to 27 and 27 and above.
That
Okay.
is for adult. For children,
This age group also, that is a adult equivalent. Adults, it is 25 and 30, but in that age group, it is 23, 27.
okay.
That is one thing in the anthropometry part. In the always the last slide is very important. The management, you covered everything. A patient's last moments of life should be made comfortable. All those points are important. So a little bit of a social life of the child, that's all mentioned here. As Kalpana was mentioning, those who have made this guidelines, that's a wrong guideline. Avoid screen time and junks. Junks, of course, but not avoid screen time, because for them, that's the only way in which you can contact with the peers. So what ideally should be done during that period is the palliative care for this sort of a children, to make the home, inside the home room life comfortable, because inevitable death happens after some time. So whatever life is there, make it comfortable some way. So out of which in a miniature school environment, to get the classes taken and
He is actually receiving online classes, actually.
yes.
And interaction and video call, everything is it's a more important for this group of children. Very important. Then one more point is always include the mother's cough. And mothers, you should see the mother and the other sibling also.
Yes.
Because those things are very important. The inheritance pattern, all the case discussion, I totally agree, because the analysis was excellent. In a case like this, most likely is a peripheral weakness, but there is a possibility always the combination of the emotional, behavioral and all, there is a possibility of dystrophinopathies. So you have included all the central part, analyzed the distal weakness, again the muscle and the neurological thing. And the second possibility, of course, the late onset SMA, all those things, and the late onset rare possibility of POMB, all those cases, totally analysis was excellent. I totally agree with that. And the one comment is about the overall presentation. Better, Mohandas also, hereafter, better to give a case which is not worked up, or a case to be given who doesn't know the workup. Here, when the case is fully worked up and given to a person, it's a biased approach.
Yes.
So a case from another institution to be given where the diagnosis is not mentioned. Forget about the diagnosis. Whatever diagnosis, it doesn't matter. So that will be a better discussion, because in this case, there is a little bit of a bias always about.
And also the power examination and all, if you can take some videos, we can just tell something. Otherwise, if you are telling grade 5, I also can say only grade 5 only. How can I say that it is not a grade 5?
Again, in the slide of a power analysis, there was a comment from Kalpana. That is a little in-depth of the power analysis needed. Bilateral, proximal, flexor, extensor and all, because this is a situation where lot of imbalance is likely. Even in the hip, flexor, extensor difference will be the proximal, distal difference will be the, and you have mentioned about the angle part. When there is a contracture, you have mentioned. When there is a contracture, that will affect your reflex center power.
Yes.
Okay. Here, your power is both the same. So you are contradicting your own statements. So all those minor points you need to consider. Otherwise, it was an excellent effort. And Shakeel, you answered all the questions. You have completely prepared. Very, very well prepared. And the mentor also. Very good.
Thank
That's a time.
Sir,
Srinivasan sir is there. Oh, he has left.
probably sir has left, I think. Shakeel, can you stop sharing the screen?
Sure, sir.
One or two points which I thought mentioning. It was an excellent discussion. And you told that child was absolutely normal till 3 years or 5 years. So if you ask carefully, you are saying that child was running normally. It is very unlikely that a child with Duchenne muscular dystrophy would run normally at any age. It's extremely unlikely. So if you ask, they will say his running was totally different. He was something like a shuffling, like that. And
He has mentioned like 5 years, but preschool itself, he was preferring to sit most of the time. Some history is there actually. Like
so
he was
they never run well, isn't it, madam?
No, so actually, they had given me a video of him running well, but I
And
couldn't put it up.
another thing regarding this autosomal dominant inheritance, usually we get incomplete penetrance and variable expressivity, so that the disease severity will be variable in different affected individuals. And this anticipation is mainly for those conditions with the triplet repeat expansion type of disorders. That also is having an autosomal dominant type of pattern. But in successive generations, the disease severity is more or the age of onset is earlier. So it is not applicable for all.
Some diseases in tuberous sclerosis you can get, which is not an autosomal, this triplet disease. But commonly we discuss in Huntington's disease, etc.
Okay. It was an excellent discussion, and Shakeel has answered all the questions. Congratulations. And it was a nice overall total discussion on Duchenne muscular dystrophy.
Srinivasan sir is there, I think.
Sir is there.
Lalita Mad also is there.
I was there throughout. I just wanted to say nice, excellent discussion, Kalpana, because Shakeel is our own. So there's no comment about that. But I just wanted to ask Kalpana whether you can anyway correlate this illness of the father. Because we are trying in
actually, truly speaking, we have to examine him. In a case, actually, definitely we have to see what it is. But because the genetic diagnosis of Duchenne is there, we cannot say. Otherwise, what we usually see is those who are telling like polio will be hereditary spastic paraplegia, and the father is affected, child also will be affected. So there will be many diseases we come across like that.
The mother says perfect, repeatedly that repeated fractures. Bone
maybe an osteogenesis imperfecta, maybe osteogenesis
imperfecta. It's a totally different condition. It is
maybe totally, yeah. Some imperfecta and all, one of the papers it was written. So
osteogenesis imperfecta tarda may be the possibility, because old age itself, he developed it after the age of 15 years, and by 22 years it became wheelchair bound.
But his intelligence is normal. He is doing some, I think, digital.
Intelligence is normal. That is true.
Whenever you have male-to-male transmission, X-linked conditions are out.
That is true.
Okay. Anyway,
thank you.
Dr. Swapna was the mentor. Swapna,
Swapna has learned it completely and
unmute it. Yeah. Thank you, Kalpana madam, for that excellent discussion. We really learned a lot. Thank you so much. Also, we would like to thank IAP Trivandrum and the PG Club team for giving us this opportunity. Thank you.
Dr. Anand is there? Ananda Keshavan?
They have left.
Okay.
Srinivasan sir's comment also last.
Thank you, Varanya.
Srinivasan sir. I am a student. So many people are there and very well discussed. Of course, that point is well taken, that a person who is presenting should see the case and present, and whatever he wants, we can give the inputs to any investigations. Of course, that is how we train for examination. But of course, here the case is well known. I think that point is well taken, Dr. Purushothaman. I think it is should be some say this thing should be there, suspense and differential diagnosis, and then when whatever he wants, that particular investigation result can be given. I think your suggestion is very valid. I hope, I don't know what about other persons
But
think.
there is a practical difficulty, no? Different
No, I
centers.
know. We cannot,
Different
we cannot this thing. But of course, Professor will be there. But anyhow, very well attended by people. People have joined the lost, and it's a wonderful thing which is going on. Yeah. This is, of course, important for institutions where there are not many patients, so many private medical colleges. But of course, in usual colleges where there are so many patients admitted and pages are well trained, so there will be no problem in clinical examination. Thank you, madam. And of course, I am more as a student here rather than as a teacher. Okay. Thank you.
So you were the examiner for all of us, sir, for many years in medical college.
Yes.
Thank you, sir.
Can we wind up?
Good night, all of you.
Yeah, right.
Nice. Good night, sir. Good night, Lalitha.
Thank you.
Good night. Okay, bye.